Good evening, everyone. Welcome to First Aid AMC MCQ. I am Dr. Arshan. I am going to be your coordinator for this 5 months MCQ course. So if you guys can hear me properly, just let me know. If there is any concern, then also just message me in the chat box. I can see that many of you are in our Facebook Live as well. So if you guys have any trouble to listen to me, just let me know. I will have a look time to time in the Facebook as well. Normally, we don't take classes on Facebook. It's just during these trial sessions and the free 2-week session. Normally, we also go just stream this class on the Facebook Live. Okay, so it's a good idea to come to the Zoom sessions because in that way you can interact with me much easily. I'm just waiting for one minute just to see that if others are joining, and then we will start the session. Okay, so just give me 1 more minute and then we will start. Thank you. Okay, so we can start now. So let's do a little bit of introduction about First Aid AMC MCQ, and then we will move to our tonight free trial session, which is the psychiatry theory. So First Aid AMC MCQ is a very well-known, highly recommended online course for those of you who are preparing for passing the MCQ as well as clinical. As you can see in our Facebook group that we have almost the highest number of candidates who pass in the MCQ and also in the clinical exam. And we have been helping the candidates like you for a long, long time. So we have a very, very strong experience on this field. And candidates love how we normally show the classes, how we normally take the classes. So you are going to also go through our free sessions, and then you can make your decision that if you are going to take the classes or not. We allow you to do 2 weeks free sessions with us. And that's a part of our course as well, which means that your free 2-week sessions is going to start from 13th of December. You might have already seen the schedule in Facebook group. So today is just the trial session. This is not even the part of the 2 weeks free session. So our course officially is going to start on 6th of December, but normally we just take another week to start the free session so that we can upload everything in your portal where you will get all of your materials, video recordings and everything to pass this exam. I know that many of you having a lot of questions in your head that how to do the preparation and what to read. Okay, so we will have all those questions answered in your orientation session for those who are enrolling into the course. But in this 2 weeks free session, also we will give you some idea that what to read for this MCQ preparation and how you can prepare yourself in a very well organized way. Because a lot of candidates just waste 3 to 5 months just to understand how to prepare. But with a good guideline, you will not waste that time, and you can utilize these 5 months to prepare yourself in a very well structured way, and you can pass the exam just after finishing the course. You can see in our group that how many candidates passed in October exam. Still, I am getting messages that doctor, I have passed the exam. So far I have got 16 candidates who has passed October MCQ exam. So you can actually have an idea that how this can happen. Obviously, our candidates do a lot of hard works, but with a good guideline, they can thrive. And that's what we are doing for these candidates who are struggling to pass. We get candidates like who fail the exam 3-4 times, and then they come to us, and immediately after finishing the course they pass the exam. So that means that something always is there which we can show to you so that you can pass the exam without failing, because you don't want to fail the first attempt, which means you don't want to fail the MCQ exam, because it is not that hard if you know what to do it, if you know how to make sure you don't tick the negative questions, or how to avoid ticking the wrong questions. So if you understand the tips and tricks, if you know what are the traps the examiner give you in the exam question, it's not very hard to pass the exam. So your main focus should be passing the MCQ in the first attempt. Okay, so, and I would definitively recommend you to go through any course, because the course can help you to understand it in a very well organized way. You can learn a lot of things from someone's post, someone's Facebook group, but still a course is important to get to understand the exam in a full way. All right, now let's not do much talking. Let's start our session tonight. And at the end of the class, you guys can ask any questions about the course. And I will also go through the course details after the class. So we'll just go through what the course entails and what you are going to get from the course. Okay, so we'll give you some idea, but let's start the class and then we can do that. So for MCQ exam, the format is, it's a software-based exam, which means it's not a paper-based, and that means that you will need to go to the exam center and appear the exam in their computer. The software has a lot of variation, which means that it has like an enormous amount of questions, and every questions will be different. That means if 20 people taking exam in one center, all those 20 candidates will get different kind of questions. So it just happens randomly, software is supposed to give you questions. And also how, if you can get a easy question correct, then the software is designed that it will give you a little bit more harder question. And then if you can answer it correctly, then software is going to give you a little bit more harder question. So there are some score of that. Now you might be thinking that if I make it correct, then I'm going to get hard question. How this makes sense? It makes sense in a way that a candidate can get all easy question, and he might think that he will pass the exam, but eventually he will fail the exam. On the other hand, someone who got a lot of hard questions and he or she came after the exam thinking that, well, I will fail this exam, but seems like that candidate passed the exam. Because what happens is that if you can get high marks by correcting the hard questions, it becomes easier for you to pass this exam. Because someone who has got a lot of easy questions, that means that candidate actually made easy questions wrong. And if you can't answer easy questions correctly, there is no way you will pass that exam. Okay? So you get 150 questions and you will get 3.5 hours to finish that 150 question. There are 20 non-scored question out of this 150 question. So 130 is scored and 20 is non-scored. or pilot, you don't know these 20 questions because it is just blended with this 150 question, and no one knows which one is pilot and which one is scored. Now, pilot questions are usually very different from usual questions because most of the time they are very hard and a very long case. So that's one of the way to know that this might be a pilot case. Remember one thing, that the last 20 questions is always a scored question, and you will need to finish 150 questions and then tick on the software that you finish the exam. If you can't finish 150 questions in that time, your result will come as fail, even though if you pass the exam. So that means that whatever happens, you will have to finish 150 questions, and you will need to tick or click on that portal that yes, you have finished the exam. Remember this part because a lot of candidates they did mistake in this part. Even they finished 150 question, but they did not click on that part that I would like to finish my exam, and then their exam was not uploaded, and they just failed the exam. So this is a very unfortunate thing to happen. So now you know, so don't do that. So that means that you will have to finish this 150 question to get at least your result, either pass or fail. If you don't, the result will become like withhold, or result will not be published even. So remember that part. Your passing score is 250 out of 500. No one knows how they score you in the exam. This is a gray area because you don't know which question carries how many marks. So there is no way you can understand that how you got pass or fail mark. So this is something called AMC scale, which will be given after your exam. You can see the score passed mean if your score is more than equal to 250. The AMC exam is those 150 questions. Each of the questions have 5 options, and it's just a single based answer. So they will give you one question, then there are 5 options, and you will need to choose the best correct option. Okay, so that's the way of it. There is no negative marking. You can only get positive marks. Another important thing to remember is that you have to answer a question before you can go to the next question. Previously, you could flag a question that you are confused about. And then at the end, you could just come back to that particular question and change the answer. Nowadays, the AMC has changed it, and you can't do that. So you have to be sure of your answer when you are giving that. So that means number 1 question, you are not sure that what might be the answer is. Still, you will have to press in one of the options. As long as you don't do that, you can't go to the next question. Okay, so that's how this will work. And there is no flagging of the questions. So that means that once your 150 question is done, the exam is done. You can't go back and change your answers. Okay. Now, what are the main subject which AMC usually give questions from? So medicine has the highest amount. So 30% questions come from medicine, surgery 20%, obs and gynae, pediatrics, mental health, and biostat or population health 12.5%. Okay, so obs, medicine, surgery, gynae, obs, pediatrics, mental health, and statistics or population health is your main topics. Now, they don't usually follow this pattern always. It's totally different. Sometimes you might get a lot of questions from pediatrics, but less amount of questions from medicine. It can happen. Did you guys get a basic idea that how the questions and how the exam will happen, you can always write in the Zoom chat box about any confusion that you have. I always keep it open so that I can answer you immediately. Same with the Facebook group. You can also write it in the comment box and I will be happy to answer you. All good. Now, moving on. Yes, Dr. Shah, no, you can't move back to the previous questions. Let's have a look at what are the books that you need for your psychiatry preparation. So for psychiatry, we are going to follow JM 8th edition. So there is no longer 7th edition we are following in the class. We follow the 8th edition all the time. So JM 8th edition, Kaplan Step to CK. So this is the USMLE Step to CK book. And it's a very, very good book, which you will need for a lot of preparations. Okay, so we'll go through that. And for psychiatry, we normally go through this Kaplan Step to CK. Okay. The websites that you can go through, we always make sure that if you are looking for some topics in the Google or any other website, always ensure it's Australian guideline because other guidelines will not work. So the guideline for psychiatry you can use is RAND CP or Medscape. Not too much important. Very, very important is UWorld USMLE. UWorld USMLE is also a USMLE book, which will help you to get a basic idea about psychiatry. Now, psychiatry is a very different topic for most of you because you haven't done a lot of psychiatry in your medical college or university life. But for AMC exam, psychiatry plays a vital role because many questions are very, very complicated. And if you don't have the basic of psychiatry, you'll not be able to answer those questions. And the questions are pretty big in the exam. So you'll need to have a good basic about it. And the basic, usually you can get it from this UWorld USMLE book. And obviously our lecture note has almost everything that you need for psychiatry. So we will go through that. And once we finish the psychiatry, then we will also do some psychiatry question solvation. And that question solve class usually happens after finishing a particular subject. Like we will take maybe 3 or 4 psychiatry class. And after that, we will also do a psychiatry question solve. Okay, and that way you can find out that the theory class that you had with us, is it helping you to solve the questions? Okay, so that's what we call as theory-based question solvation class. Okay, so no, there are no negative marks. If we want to solve question later on, what is the option? You can solve questions in our portal, and that's totally fine. We will go through the question solvation later on. Yes, so UWorld is MCQ. So in UWorld USMLE, you will get that lot of questions about psychiatry, and then you can also solve those questions, find out the answer and read the answer in detail. We normally give you the PDF books for UWorld USMLE in the course, so you will be able to go through that. You don't need to buy that. That's right, Dr. Sharoz, that if you can't answer one question correctly, the next question is relatively easier. That's very true. Yes, you will be able to access all these books and everything from this course, so you don't need to buy anything. Yeah, and a couple of things which you might need to buy for a hard copy, which we will discuss. Yes, we have original computer-based MCQ exam. Okay, so you can use our portal for just similar like MCQ exam, we have at least 3 to 4 150 question mock test and a huge amount of multiple mini mock test. Okay, so you can do that. Now the question Dr. Fayaz asked that, do we have that much time to go through that many books just for one subject? No, basically it's not about like you will have to go through all this book without knowing what you need to go through. The part of the course is to understand what topics are important, and you will just go through that particular topics from these books, and not every topic. So some topics you will get better in JM or John Murtagh. Some topic you will get better in Kaplan. So the idea of the course is to understand which topic is important for your exam. Yes, we will provide you the URL, Dr. Shah. No, you can't change your option after you have done it once, as long as you are not going to the next question. Once you go to the next question, you can't change the option. But if you haven't clicked the next button, you can change your option. Let's start. So starting with psychiatry. Let me know anytime that if you don't understand any particular topic, the questions about the course, ask it at the end so that we can go through. Because every questions that you are having, I'm going to discuss with you. So at the end, we will come to the course detail and you get to understand what this course has and everything. And then if you have questions about the course, feel free to ask me. Okay, let's just start with our class tonight. No, the JM is not sufficient for psychiatry. JM has very small amount of psychiatry topic, which is not even 30% of your preparation. So starting with depression, very important topic for the exam. Depression or major depressive disorder, what does it mean? So if we have a look at here, you can see that a 70-year-old woman recently admitted after her son informed the doctor that she had been doing very poorly over the last few months. Patient reports weight loss, decreased concentration, feeling of helplessness, hopelessness, decreased energy, depressed mood, and decreased sleep. So to diagnose major depressive disorder, the DSM-5 criteria is that you need at least 5 out of the 9 symptoms in here. And at least criteria 1 or criteria 2 is essential to diagnose someone with major depressive disorder. It's very important to know that the symptoms should be there almost every day for at least 2 weeks to diagnose them as MDD. So what are those 9 symptoms? We follow this mnemonic called M-SIGE-CAPS. So M for mood, so either a low mood or irritable mood. S for sleep problem, so many patients will have insomnia or some patient will have hypersomnia. I for loss of interest. These two yellow one, number 1 and number 3 is the most important criteria for diagnosis of MDD. So at least one of them has to be there to diagnose. So loss of interest is also known as anhedonia in psychiatry term. Then G for feeling of guiltiness or hopelessness, worthlessness. E for lack of energy. C for concentration impairment. A for appetite change. Most of the depressed patient will lose appetite. Some can have increased appetite. If you have lack of appetite, you will lose body weight. So that can also happen. P for psychomotor changes. So psychomotor changes can be either a psychomotor agitation or psychomotor retardation. So psychomotor retardation means that patient becomes very slow. So patient will say, I'm very slow to do things. That's psychomotor retardation. And agitation means that they will be very agitated, irritable, frustrated all the time. And the most important question that you need to ask to a depressed patient is suicidal ideation. So questions come in a lot of ways from this symptom. First question is that which is the most important criteria to diagnose MDD? So that's either low mood or loss of interest. Sometimes they ask you, what is the most important question you will ask in this particular patient? So if any depression question, if they ask this question, you will need to choose suicidal thought, because that's the first thing you need to rule out. That is this patient having an active suicidal thoughts? All right. All of these are typical depression symptoms. But what are the atypical depression symptoms? The atypical depression symptoms are increased appetite, increased weight, and increased sleep. So that's also come in exam time to time, that what is the atypical feature in this patient? So atypical features are body weight increase, increase of appetite, and increased sleep. Because the typical symptoms means that patient with depression will lose appetite, will lose weight, and they will have trouble to sleep. Now you do understand that normally you will need at least 5 of these symptoms for at least 2 weeks to diagnose them as major depressive disorder. Okay. You can see here that the 2 criteria for major depressive disorder in the DSM-5 is pervasive depressed mood. So you will need a depression mood. You also need a marked loss of interest or pleasure, otherwise known as anhedonia, persisting for at least 2 weeks. And the other criteria we already discussed. Apart from major depressive disorder, there are also some other depression criteria. Like one of them is called persistent depressive disorder, or PDD. What is persistent depressive disorder? If someone has got a very mild severity of depression for a long time, at least for 2 years. So long-standing depression of mild severity, at least for 2 years, is known as persistent depressive disorder. Okay. Now, major depressive disorder has been divided into 3 categories according to its severity. So mild, moderate, or severe. We will come to the point that which is mild and which is moderate and which is severe. In a basic way, remember one thing, that severe means if someone has got psychotic features with depression, like having hallucination, delusions, or someone having active suicidal thoughts, they are also high risk, or you can say they are having a severe depression. Because you need to know mild, moderate, severe to treat them accordingly. Before going to the treatment, let's have a look at how we diagnose depression in children and adolescents. And even before that, just remember the main part of treatment for depression depends on its severity. Like if it's a mild to moderate, you'd like to start with psychological therapy, which is commonly known as cognitive behavioral therapy. And in cognitive behavioral therapy, you send the patient to a psychologist, and the psychologist is supposed to hear the patient's problem, and then they will try to convert their negative feelings to something positive about themselves. That's what we call as cognitive behavioral therapy. That's usually the first line treatment for a many psychiatric condition, including the mild to moderate depression. But when it becomes severe depression, the treatment of choice is medication along with CBT. So the medication that we commonly use for depression patient is called SSRI. That's your first line medication for depression. We will come to this SSRI in detail later on. Okay, let's have a look at how we normally diagnose depression in children and adolescents. Now, unlike adults who normally present to you with low mood, crying episodes, the depression in children and adolescents is a little bit different. They come to you mainly with frustration, angry, and they will not cry in front of you. They will be very angry and irritable most of the time. Okay? And they can have feelings of despair. They can feel helpless, worthless. Those are also not uncommon. So for children, usually the presence of sad or irritable mood, loss of interest in usual activities, like if they don't want to go to the school, if they don't enjoy going out with the friends, that's the time you should think about possibility of depression. You can see here in children, irritability may be more prominent than sadness. Other than that, difficulty getting to sleep, not enjoying meals, poor concentration, low self-esteem is also a part of depression. One of the important questions comes in exam. What is the most appropriate antidepressant for a child diagnosed with depression? So what do you think that if you have tried CBT, it did not work, and now you want to try with a medication for a child, and you want to give an antidepressant, what is the best antidepressant to offer? Anyone? Yes, Dr. Van, very good. So not just SSRI, which SSRI? That's the question. Everyone knows that it is SSRI, but question will be what is the SSRI that you are going to give? So normally fluvoxamine or fluoxetine is your choice. Okay, so there is a lot of SSRI in the market, right? So citalopram, fluoxetine, fluvoxamine, sertraline, paroxetine. So there are lots. But the question comes that which one is the best for children? For children and adolescents, the choice will be fluvoxamine or fluoxetine. Any of them is the best. Okay, so that's the important question for your exam. Then there is a term called recurrent brief depression. It is not a very uncommon condition to have this brief depression in which patient will have recurrent episodes of depression of very short duration, just for 3 to 7 days, and it can happen 3 to 4 times in a month. But you can't diagnose them as MDD because to diagnose MDD, you need at least 2 weeks of depression. So that's why we call it a recurrent brief depression. Many times it might be related to menstruation in a girl or female. But the problem with this kind of brief depression is that usual antidepressants are not effective in this case. So the alternative medication is lithium, and initially you can just start them with cognitive behavioral therapy. So if they ask what is your initial management, that should be CBT. If they are asking for any particular medication, that should be lithium, not SSRI. There is also another condition called seasonal affective disorder. That's mainly some people who live in cold climates. They get a recurrent brief depression during the cold climate only. So that's what we called as seasonal affective disorder. Treatment is same, psychotherapy, which is CBT. You might need to give them some phototherapy, and last option is SSRI. Not very important for exam. Coming to the management guideline for depression. So you already know that for mild to moderate, psychological therapy is your best option or first line option. For severe depression, antidepressant. Along with that, you can also add psychological therapy. Now, let's say that you have done psychological therapy, you have done antidepressant, but still patient is severely depressed. And along with that, patient is also psychotic. Severe depression with psychosis and resistant to medication, that's the time you will try another option that's called electroconvulsive therapy or ECT. That's the last option for any any severely depressed patient who is resistant to all other forms of treatment. Okay. Let's have a look. Before I ask you to answer this question, remember one other thing, that antidepressants criteria, the first line antidepressant is SSRI. And this is not just the only one SSRI or only one medication. There are a couple of other group of medications which also classified as antidepressant, like tricyclic antidepressant, like amitriptyline, okay, nortriptyline, all of them. Then also there is MAO inhibitors like selegiline. Those are also antidepressant. We normally don't use MAO inhibitors anymore, but still sometimes we can use tricyclic antidepressant, but those are second line. The first line is always SSRI. Now let's go through this question and let me know what you think about it. So a 72-year-old man comes to the office due to worsening depression and insomnia since his wife died 7 months ago. The patient experienced lethargy, so lack of energy, tearfulness. He has little interest in socializing with his married friends. He has already attended 3 sessions of psychotherapy. However, the patient continues to feel depressed, now also having severe insomnia. He has difficulty falling asleep, frequently lying awake at night, feels very guilty about her death. The patient experienced a moment of severe depression last week in which he briefly thought of suicide. He also lost a significant 4.5 kilos since the wife's death. Which of the following is the most appropriate next step in the management of this patient? A lot of time you will come across this kind of question, most appropriate next. Remember one thing, that if a next is in your question, it means the initial treatment they're asking. If only most appropriate they're asking, then that means it's a definitive treatment they're asking. So this is a very confusing kind of question in AMC. You will come across a lot. Most appropriate next, most appropriate initial means that they're asking for the initial choice of treatment. But if they just ask you what is the definitive treatment, what is the most appropriate treatment, that means they are asking the best option that you have. So you can obviously find out that this patient having major depressive disorder, right? So you can see the criteria, that lack of energy, then insomnia, then obviously tearfulness will be counted as low mood. You can see loss of interest, guilty feeling, suicide, right? So at least six of the symptoms are already here. So it is a diagnosed major depressive disorder anyway. So what you want to do, you want to increase the frequency of psychotherapy, prescribe amitriptyline and continue psychotherapy, prescribe mirtazapine and continue psycho, prescribe zolpidem, provide reassurance, or recommend electroconvulsive therapy. What will you do? Sometimes it is not a bad idea to exclude your unlikely answer. So what are the unlikely answer? Zolpidem is an antidepressant. Zolpidem is a benzodiazepine. You never give benzodiazepine for a major depressive disorder. Okay? Only reassurance will not be helpful. Electroconvulsive is not our next option. Even with just frequency of psychotherapy, it is not going to help. You'll need to add a medication because this patient is severely depressed. Why? Because of the suicidal thought. So what you want to do, you want to prescribe amitriptyline and continue psychotherapy, or prescribe mirtazapine and continue psychotherapy. Basically, Mirtazapine is better option than amitriptyline. Amitriptyline is a tricyclic antidepressant. It's a second line option. Okay, so mirtazapine is better option than the tricyclic antidepressant in that way. And why mirtazapine is also important, that mirtazapine is a highly sedative drug, and that can help the patient to sleep, because this patient is actually having trouble to sleep. Okay. So that means that it's mirtazapine is a atypical kind of antidepressant. It does not fall into SSRI, does not fall into TCA, but it's a kind of atypical one. But why it is important? Because mirtazapine is a highly sedative drug. Someone who is struggling to sleep and also depressed, even better than amitriptyline is mirtazapine. So that's the reason we will choose the option C rather than option B. Okay. Amitriptyline is also not a bad idea. That's the time you get confused in the exam, because time to time you will get two options which is very close to each other, and you will just be very confused which one to choose. Okay, so you will need to be just careful about it. No, amitriptyline is not SSRI. Amitriptyline is tricyclic antidepressant, which is a second line drug. Any question with this one? No. So mirtazapine is not SSRI. That's the atypical antidepressant. And it's not even a SNRI. SNRI are venlafaxine, desvenlafaxine, those drugs, duloxetine. So those will be your SNRI. But mirtazapine is an atypical antidepressant, or you can say, you just say that it's an atypical one because it does not fall into a classic class of antidepressant. The main reason why we are choosing mirtazapine here, because there is no SSRI in the option. If there was a SSRI in the option, then we would choose that. The other option is amitriptyline. That's our second line option. Even better than amitriptyline is mirtazapine, just because of the fact is that the patient is having like a sleeping trouble. That's why we go for that. No, it's mirtazapine is not also in TCA group. It's an atypical antidepressant. Okay, so moving on. So that's one of the confusion that you will get in the exam as well. You will always need to choose the best possible option for the patient. Okay, because both B and C is correct answer, but you can't choose two. You will have to choose the best one. And that's where candidate get it wrong. Candidate struggle in the exam. Okay. Moving on to some of the SSRI side effect. So the common side effect of SSRI is that some can cause insomnia, some can cause sedation, some can cause increased or decreased appetite, but among many of these, the common is nausea, headache, and sexual dysfunction. Go through this because it comes in exam sometimes. And these are all the commonly used SSRI. So fluoxetine, citalopram, escitalopram, sertraline, paroxetine, and fluvoxamine. These are the commonly used SSRI. Okay. So, and you can see that most of them has some side effect. Common one is headache, insomnia, feeling anxious, drowsy. Some can give nausea, vomiting, GIT upset, and almost all of them will give you a sexual dysfunction. Mirtazapine. What are the side effects of mirtazapine? So why we are discussing about the side effect anyway? Because the pharmaceutical side effect is a very commonly asked topic in the exam. So you will need to know the common medication side effects. Okay. Like mirtazapine, it causes severe sedation, as you can see. So that's why we chose this one. It can cause constipation. It can increase the level of cholesterol, weight gain, and increased appetite, sometimes even decreased appetite. But the main side effect is severe sedation. The other important one is venlafaxine, commonly known as Effexor. Venlafaxine, desvenlafaxine is a part of SNRI, and this is also a very commonly used antidepressants in Australia, even more used than tricyclic antidepressant. Okay, so what are the side effects of venlafaxine? The common side effect is that it can cause insomnia. It can give you anxiety, headache, loss of appetite, ejaculation disorder, dry mouth, sweating, and weight loss. Now, this is one of the medication which is antidepressant, but can also cause weight loss, because most of the other antidepressant causes weight gain. So in exam, time to time, they will give you that patient is very concerned about weight gain. What do you want to give? There's the time you will choose venlafaxine. Okay. The serious side effect of venlafaxine is important because it comes in exam. It can increase blood pressure. So a patient who is severely hypertensive, you will not give venlafaxine to that patient. It can increase the threshold of seizure. So a patient diagnosed with epilepsy, you will not give venlafaxine to that patient. It can increase the risk of suicidal thinking in children, but it does not mean that you will not give venlafaxine to anyone because of this. You will just need to monitor the patient initially when you start it. A very important question comes in exam from venlafaxine side effect is that sometimes this medication can reduce the electrolyte level, which is sodium. So someone who is taking venlafaxine, if they come to you with confusion or sudden change in their mental status, think about venlafaxine-induced hyponatremia. Okay, so that's one of the other important side effects. Before I move to some more complex side effect, couple of important SSRI-related side effect comes in exam. Let's say a patient started with sertraline. And sertraline is a very commonly used SSRI. Okay, so you have started a patient with sertraline, and so after just 2 weeks, patient started to have severe tummy upset, which means nausea, sometimes even vomiting, having some diarrhea. So patient can't tolerate it. What will you do? In other way, patient's depression is getting well controlled. What are you going to do for this patient? The option might be like you want to change sertraline to another group of antidepressant like TCA or maybe MAO inhibitors, or you want to change sertraline to the same group of antidepressant like another SSRI, or you want to just give some antiemetics and ask the patient just deal with it. What will you do? Guys? Anyone? Very good, Dr. Jenny. So the mean is that the question means that if a patient is on a SSRI and they get a tummy upset, or a GIT side effect, but their depression is getting well controlled, the best idea is to switch it to another SSRI. Because likely chance that with the other SSRI drug, patient will be fine. Because before changing into another group of antidepressant like TCA, we will try our best to try some other SSRI. Because a patient can have tummy upset or GIT upset with one particular SSRI, but not the other one. All right. So if a patient comes with a GIT side effect after having a SSRI, but their depression is getting controlled, your best idea is to just change it to another SSRI. Okay. Now, second question. A patient who you started with sertraline, 100 milligram, now started to get a severe erectile dysfunction, and now wife wants to leave the patient because of that. What will you do? The depression is well controlled with 100 milligram. Your option is 1, ask the patient to wait, because sometimes it will be resolved by its own. Second, you want to reduce the dose. Third, you want to change SSRI to some other form of antidepressant, maybe a atypical one. Fourth, just add Viagra or sildenafil. What will you do? Okay, the correct answer is that, first of all, you will have to look into the question. If a patient is on 100 milligrams sertraline and their mood is well controlled with that, but they are getting erectile dysfunction for that, and it is very significant, you can't wait and watch. You'll have to do something, because the marriage is going to be end for that. So the best option in this case is to reduce the dose first and see that with reduction of 100 milligram, you can reduce it back to 50 milligram and see that if the erectile dysfunction gets better. Many times it gets better with reduction of dose, but you can only reduce the dose if their mood is well controlled with that 100 milligram. Let's say with that 100 milligram, their mood is not well controlled. Then you can't change it, because then they will be depressed. At that time, the option is to change this SSRI to another antidepressant which has less side effects on sexual dysfunction. Now in here, if you change from one SSRI to another SSRI, it will not work, because almost every SSRI has similar kind of sexual dysfunction. So that's the difference. GIT upset, you can change it to another SSRI, but sexual dysfunction, you will need to, if you need to change it, you will need to change it to something atypical. And the best atypical antidepressant which has lower effect on sexual dysfunction are, one is called bupropion, another is called that mirtazapine is also good, and there are other two which is very strange kind of name. It's called vilajodon and then there is one called vortioxetine. You don't need to even remember this last two names. Forget about it. Just remember bupropion and mirtazapine. So these are all atypical antidepressant. So they have the least sexual side effect. Okay. So you can change this SSRI to this antidepressant. And the last option is to add a sildenafil or Viagra. Okay, so first is reduction of dose if it's possible. If not, then change it to something else. Even if it's not possible, then add Viagra or sildenafil. Clear, guys? So these two questions come in exam very frequently. If you have an idea, you can easily answer them. Otherwise, it can get really confusing. Now, when you are changing medication like this, like let's say you want to change a patient from sertraline to citalopram because patient cannot tolerate sertraline. Can you just change it immediately? No, because sometimes what happens that if you just stop sertraline and start this citalopram on the same day, patient's blood will have the effect of sertraline for another couple of days. So the idea is called give a washout period when you are changing one antidepressant to other. Okay, so what we normally do that we know that we want to switch sertraline to citalopram. We will gradually reduce the dose of sertraline and then stop it over few weeks time. And then we give a washout period of couple of days. For sertraline, maybe you'll just give 3 days, but still you'll need to give a little bit of time. And then you restart the citalopram. From a low dose, you go to the high dose. That way, your body will not get 2 antidepressants at the same time. Okay? No, we don't do that. Reduce the dose at the same time and start another one. That's for psychiatric medication or antipsychotic medication. For antidepressant, this is called washout period, where you give a time when the patient will not take any antidepressant. So you will gradually reduce the first dose and stop it. Give a period where there will be no medication, usually for 3 to highest 7 days. 7 days is mainly for changing fluoxetine to something else. And then you gradually restart another antidepressant and increase the dose. Okay? So that's another important topic which comes in exam. You don't need to know each and every specific washout period, that they don't ask it, but at least know the idea so that if it comes in the exam, you know what to choose. Okay, now let's move on to the next one called serotonin syndrome. Serotonin syndrome is a rare side effect of SSRI, but it can be quite serious if it happens. So it's a serious, even sometimes life-threatening adverse reaction to the use of SSRI or other serotonergic medication. Which means that if your body got multiple serotonin medication, it can have a condition called serotonin syndrome. So usually it happens either if you have given like 2 or 3 serotonergic medication at the same time. Like let's say one doctor started sertraline and then that patient came to you and did not say that he is on sertraline. And then you found out that patient is depressed and you have given another SSRI, let's say fluoxetine. So what happens that patient now taking 2 kind of SSRI. That's something which can be really troubling. So before giving any serotonin medication, you will have to always find out that if the patient taking any medication which can increase serotonin in their body. Sometimes even if you just suddenly increase one dose from a low dose to high dose, patient can get serotonin syndrome. So symptoms must coincide with the introdose increase of a serotonergic agent. The commonly ones are antidepressants, SSRI, TCA, SNRI, any of those antidepressants can cause it. Very important to remember, one of the opioid, which is tramadol, that can also give serotonin syndrome. Stimulant drug like amphetamine, methamphetamine, MDMA or ecstasy, Some other illicit drugs, antiemetics like metoclopramide, lithium, and selegiline, which is one of the MAO inhibitors. So all of these can increase the possibility of serotonin syndrome. What are the symptoms you will look for if you are thinking about serotonin syndrome? We call it first CNS effect or mental status effect. So you will get confused, agitated, sometimes even seizure-like activity. Then it can also affect the muscle. So altered muscle tone causing tremor, shivering. You can get hyperreflexia and myoclonus. Autonomic instability causing hypo or hypertension, tachycardia, fever, diarrhea. This is how it looks like. If you look at this patient, you can see that the patient looks very agitated. Their pupil can get dilated, sweaty, tachycardia, hypertensive, increased bowel sound or diarrhea. In neurological, you can get clonus, tremor, and hyperreflexia. So if you get something like that positive, that's the time you think about serotonin syndrome. There is another commonly misinterpreted one, which we call neuroleptic malignant syndrome. So in short, I call it as NMS. So serotonin syndrome and NMS can be very confusing because the symptoms are pretty same. How to differentiate between these two? You already know that serotonin syndrome happens for serotonergic drug, but neuroleptic malignant happens for psychotic medication or antipsychotic medication. The onset is abrupt for serotonin syndrome, but gradual for NMS. Neuromuscular finding, you mainly get myoclonus and tremor here, but in neuroleptic malignant syndrome, you get rigidity. Reflex will be increased here, decreased in neuroleptic malignant syndrome. You will get pupil dilated in serotonin syndrome, normal in neuroleptic malignant syndrome. So that's usually the way to differentiate between these two. When we will go to the schizophrenia question, then you will know about this neuroleptic malignant syndrome again. Now, moving on, that if a patient is on antidepressant medication, how long they need to take it? Usually, if it's for the first time, you should continue it for at least a minimum of 12 months. But if a patient gets recurrent episodes of depression, then at least 2 to 3 years. Sometimes even in some other guideline, it says 3 to 5 years. But according to JAM, at least 2 to 3 years they have to take if patient gets recurrent episodes of depression. These are the risk factor of having a relapse of depression. You can just go through it. Okay. So that's actually everything that you need to know about depression. I know it's a lot to take in, but that's how much you actually need to know just for one topic. And this is one of the commonest thing that comes in exam. Just one other thing that you need to know for depression is that if you start a patient with medication, how long you will need to see that if that medication is effective for that patient. We normally say that a patient should start feeling better by the time of 2 to 4 weeks time, but not completely better. But by the time it is 4 to 8 weeks, if still patient is not getting 100% benefit out of that medication, that means that medication is not working. So change it to something else. So at least wait for 4 to 8 weeks before changing the medication. Okay. Moving on. Any questions so far, guys? You are understanding what we are discussing in here? Is it very complicated for you? Great. Let's move on. We will give it in few minutes time, but before that, let's finish the bipolar disorder and then we can go for a break. Okay. So what is bipolar disorder? If you look at this picture, you can see that a patient's mood actually like this. So this is the normal mood. Bipolar disorder means that sometimes their mood becomes low, which is the depressive phase of it, and sometimes their mood becomes very high and they feel very good, and that's what we call as manic phase. Okay. Now, when a patient has got episodes of depression followed by episodes of mania or hypomania, that's what we call as bipolar disorder. All right, let's go a little bit detail about it. So what is the DSM-5 criteria to diagnose a patient for mania? You already know depression. So mania means at least 1 week of having an abnormally high mood. So patient will have persistently elevated mood. Along with that, they will have 3 or more of these unusual features, which include feeling inflated self-esteem or grandiosity. That means they will feel like they have some special power and they will feel like they are better than everyone. Decreased need for sleeping, so they will feel like they don't need to sleep. Very talkative and accelerated speech. Racing thoughts and flight of ideas. That means that their thoughts will be all over the place. At one time, they are thinking about one thing, then at just next, they are thinking about something else. So all over the place, their thoughts are just jumping from one topic to another. That's what we call as flight of ideas. They will be very destructible. Increased goal-directed activity, which means they will engage themselves in multiple activities. Like a patient who did not even want to go out, now enrolled himself in a community club and enrolled himself in a drama club or maybe swimming club. So a lot of goal-directed activities suddenly. That's the time you will be thinking about possible manic episode. And excessive activity with painful consequence. We normally say that they do a lot of reckless behavior at this time. This is the mnemonic that we normally use for mania. D for destructibility. That means they will be very poorly focused and multitasking and very easily distracted. Insomnia, it's not insomnia, it's called like decreased need for sleep. They will not feel that they need sleeping. And they also feel very energetic at this time. G for grandiosity, which is that increased self-esteem, feeling like they have got some superpower. Flight of ideas, which is racing of the thoughts and jumping from one topic to another. Increased goal-directed activities. Their speech will be pressured and very talkative and loud speech. And T for thoughtlessness or very risk-taking behaviors. So you will find out that over the last 1 week, patient feels very good about himself, and he's saying that I have a superpower. I can use my power to stop the watch. Okay, or they will say that I am better than my professor. He does not know anything, but I am inventing something. They will be very talkative, and they will say that they're spending a lot of money. They're doing a lot of gambling, taking reckless driving behavior, drinking alcohol, drinking lots of illicit drugs. Okay, so all of this behavior is a feature of mania. Now have a look at this question. So bipolar disorder has been divided into bipolar 1 and bipolar 2. So we'll come to that point. So have a look that 19-year-old student is taken to the school counselor after he fails several classes. The patient is enrolled in numerous classes, most of which have conflicting times. His grades are poor, yet he seems undisturbed by this. He is also enrolled in numerous organizations such as chess club, drama club, student government, sports, and at least 2 other fraternities. Speech is pressured, has psychomotor agitation. So you can see that the patient is having manic episodes at the moment. So when a patient has a feature of depression and in another time patient had at least 1 week of manic episodes, that's the time we call it bipolar 1 disorder. So bipolar 1 means depression plus another episodes of mania. The difference between mania and hypomania is mania needs at least 1 week of this kind of behavior, and it is significant enough to cause disruption in their familial life, occupational life, or social life. Whereas hypomania is less severe, usually less than a week time, and it normally does not affect their social occupational life that much. So when a patient has got depression with hypomania, that's called bipolar 2 disorder. Depression with manic episodes, bipolar 1 disorder. So that's what is written in here. We already know the typical symptoms for mania. So reckless behavior, overspending, hasty decisions like breaking up relationships, impaired judgment, increased sexual drive, energy, and activity. Hypomania, we know that these are less severe and usually less than a week duration. The very important to know about mania is the management. It comes in exam very frequently. Previously, we used to treat acute mania with some mood stabilizers like lithium, but lithium is no longer the first line treatment for acute mania. Acute mania is a medical emergency which requires patient to be hospitalized. And even if the patient does not want to be admitted, it will be an involuntary admission. A recent meta-analysis indicates that antipsychotics are the most efficacious drug for acute mania. So your first line medication for acute mania will be either olanzapine or risperidone orally. If olanzapine or risperidone is not available, then your option could be the second generation antipsychotic or first generation antipsychotic like haloperidol. So you can use haloperidol, which is a typical antipsychotic, or second generation or atypical antipsychotic like aripiprazole. There are other options like lithium, sodium valproate, or carbamazepine. These are all second line, not a first line medication. Let's say if a manic patient is very aggressive and trying to assault a doctor, in that case, giving oral medication will not work. That's the time you will have to go for some IV or IM medication, and the choice is haloperidol, IM or IV at that time. Okay, but in other cases, you will always choose either olanzapine or risperidone. But do we normally use any other prophylactic medication? Yes. If a patient has got multiple episodes of recurrent bipolar disorder, especially if a patient has got 2 or more episodes of either mania or depression in the last 4 years, you can give them a prophylactic mood stabilizers. And that is what we call as lithium, or even you can give some of the second generation antipsychotic agent like olanzapine, risperidone, aripiprazole. You can also try carbamazepine or sodium valproate, but lithium is usually the choice as a prophylaxis for recurrent bipolar disorder. If you start lithium in a patient, it's very important that you check their lithium level in the blood regularly. Usual maintenance level for lithium is 0.6 to 0.8. But if lithium level gets higher than normal, there is a chance that patient might have a lithium toxicity. So what are the signs of lithium toxicity? Patient can start to have a tremor, muscle weakness. They can start to gain weight, GIT upset. Hypothyroidism is a very important side effect. They can also get nephrotoxicity. Like lithium can cause a nephrogenic diabetes insipidus. So that's also important to know. So these are all the unwanted side effects of lithium. The important thing to remember that if a patient having a lithium toxicity feature, if it is mild to moderate and the lithium level is less than 4, the first line treatment is IV fluid or just normal saline. But if a patient has got a severe lithium toxicity, which is indicated by CNS side effect, like patient has got seizure, patient is in coma, or myoclonus, or cardiovascular collapse. So if severe features of toxicity or lithium level more than 4 in the blood, that patient will need a dialysis. So both of these is important to know. It comes in exam. Okay. The other important topic for bipolar disorder is that, first of all, you know that acute mania, you will treat it with antipsychotic like olanzapine or risperidone. But what if a patient having bipolar depression? The problem with bipolar depression is that, like, if you just start them with an antidepressant, that patient will end up getting a manic episode. So very careful. If you start a patient with just antidepressant, find out that if that patient had a mania or hypomania episodes before. Because if they have a mania or hypomania episode, that means they are not just depressed. They are diagnosed as a bipolar disorder. So patient with bipolar disorder sometimes will get mania, sometimes will get depression. The question is, when they are in the depressed phase, what are you going to give to that patient? Obviously, you will give an antidepressant because patient is depressed. But you can't just give antidepressant. You will have to add some mood stabilizers along with that. So that mood stabilizer can be any of these, either lithium, valproate, carbamazepine, even some antipsychotics. But you'll have to give something. Okay, and then you can stop the antidepressant within 1 to 2 months and then just continue the mood stabilizers. This is a very commonly asked question and many candidates get it wrong in the exam. Okay, did you guys get this one, that if patient is having a bipolar depression, you can't just treat them with antidepressant, you will have to add any of the mood stabilizers. Let's have a look that if you actually got it. So a 27-year-old man is brought to the office by his wife due to her concern that he has not been himself for the last 3 weeks. She says that he is depressed and withdrawn, sleeps 14 hours a day, has no energy or interest in looking for work or participating in any activities. Patient was hospitalized 6 months ago for an episode in which he became aggressive toward his wife. This occurred when he confronted him about staying up all night, gambling away their savings, investing a large sum of money, and that soon went bankrupt. At that time, patient spoke very rapidly, was convinced that he had a brilliant plan to achieve world peace. So what happened 6 months ago? He also experienced a similar episode 2 years ago. Which of the following medication are most appropriate for maintenance treatment of this patient? So what do you think that this patient has got? What's the diagnosis? Guys, so what do you think this is the diagnosis? Yes, it's bipolar disorder 1. At the moment, patient has got bipolar depression, right? So what are you going to treat? So you want to give carbamazepine, fluoxetine, lithium quetiapine, lithium sertraline, lurasidone, risperidone. So lurasidone is the antipsychotic, risperidone is the antipsychotic, so that's obviously out. Valproate, clozapine, valproate, haloperidol. So the basic idea is that you will need to give a SSRI and a antipsychotic or a mood stabilizers, right? So find out from here. So valproate is a mood stabilizer, clozapine is an antipsychotic, but clozapine is the last antipsychotic that you will give to a patient. So forget about it. Haloperidol is an antipsychotic, valproate is mood stabilizer. So you are not giving any antidepressant. Rule that out. Lithium sertraline, that's not a bad idea. Lithium quetiapine, now again, this is a mood stabilizer. This is an antipsychotic, so that's not going to work. Carbamazepine, fluoxetine. Now that can also work. This is a mood stabilizer. This is a SSRI. So you are having A or C. Which one will you choose? That's the question. As a maintenance treatment of bipolar disorder, best is always lithium. And along with that, you have got an antidepressant also. So that will be your best choice of management in here. Okay? See that how the theory usually helps. We already discussed about persistent depressive disorder, which means if a patient has got mild severity of depression for 2 years, that's what we call as PDD. There is another condition called cyclothymic disorder. Cyclothymic disorder is a condition in which patient will get many periods of depressed mood, many periods of hypomanic mood for at least 2 years. That means if a patient has got bipolar disorder for 2 years, then you will call them as cyclothymic disorder. Okay. Now, some of you asking about like what will be the treatment if just hypomania. Hypomania mania treatment is same. So that means you will need to treat them with antipsychotic initially. And about the washout period, someone has asked that when you change one antidepressant to another antidepressant, we give a washout time, because sometimes even after finishing the antidepressant, it can stay in your blood for a few days. So let's say you want to change sertraline to citalopram. So you will gradually reduce the dose of sertraline, and then you will stop it, and then you will give a gap of 2 to 3 days where patient will not take any antidepressant. And then you will start as a low dose of citalopram and gradually increase the dose. So that's what we call as a washout period. Okay. All right. So I know that this is a lot of information going into your head, but this will be like one of our classes, because if we need to finish your topics in a good way, in a well explained way, this is how it should be done. Okay. Otherwise, you will just get a lot of questions which you will never heard in the exam. So in our theory session, we try to make sure that you get acquainted with the questions when we are discussing the theory, so that when questions come, you already know what to expect. Okay. So let's take a 10-minute break, give your brain a little bit time, and then we will have a little bit discussion about schizophrenia, and also a delusional disorder, and then we will finish the class. Okay. So let's take a 10-minute break. Thank you. All right, everyone, let's start again. So far we have learned about depression. We have learned a lot about bipolar disorder, mania, hypomania, right? So the next topic is how to differentiate between grief and depression. Time to time, you will come to some questions where they're asking about grief. So grief is a type of, you can say it's a normal human response when they lose someone very nice and dear to them, right? Like someone lost their partner, and in response to that, they will have features of depression, right? Like they will be very sad, tearful, sleep problem, decreased appetite. So the features can be quite similar to depression, but it will not be severe enough that you will be able to diagnose them as major depressive disorder. So always there will be a history in grief or bereavement that patient lost someone, but depression not necessarily it has to be like they have lost someone. So in response to someone's death, if someone have these features, that's what we normally call them as common grief or normal grief. But grief or bereavement should get better within 6 months. If still after 6 months, someone having this grief-like feature, that's the time we call it as complicated grief or bereavement. Some patients with grief or bereavement can have psychotic features. So that's the time you call them as grief or bereavement with psychosis. Okay, so the main difference between them is that depression can continue for years and years, but grief should get better within 6 months. But if it is more than 6 months, then you will think it as a complicated grief or bereavement. Okay. The treatment of grief or bereavement is sending them to a counselor who can give them some psychotherapy, and depression treatment you already know. Moving on to schizophrenia. So for schizophrenia, it is a very commonly asked topic in exam. So try to understand as much as you can for this one. So schizophrenia means it's a psychosis in which patient lose the touch with the reality. It's not an uncommon condition, but it's commonly diagnosed in young adolescent around the age of 15 to 25. The prevalence of schizophrenia comes in exam, so you will need to know these ratios. So general population chance of having a schizophrenia is just 1%. But the chance gets really high if it is a monozygotic twin. They have a chance of 47% getting schizophrenia. So let's say if one of them has got schizophrenia, the other twin also, there is a chance that 47% cases, they will also get schizophrenia. Dizygotic twin, 12%. If you have a one schizophrenic parent, then 12% chance. Two schizophrenic parents, 40% chance. First degree relative, chance is 12%. Second degree relative, 5 to 6%. Like sometimes they will ask in the exam that the grandparents or granddad had schizophrenia. So what's the chance of him to get schizophrenia? So grandparent is second degree relative, which means that your patient have a chance of 5 to 6% to get schizophrenia. Okay. How to diagnose schizophrenia? So we say that 2 or more of the following, each present for a significant period of time during a 1-month period. So schizophrenia has these major 5 symptoms. Some of them called positive symptoms, some of them are known as negative symptoms. So positive symptoms are symptoms that a normal person should not have. So that include delusion, hallucination, and disorganized speech. And at least one of them should be there to diagnose someone as a schizophrenia. Okay, so delusion means abnormal belief, and the belief is very strong. Even if you give them a strong evidence, still they will not, they will not believe you. So that's what we call as delusion. Hallucination means a abnormal feeling or abnormal perception in which a patient can have auditory hallucination, in which patient hears someone but you can't see them. They can have visual hallucination where patient sees something abnormal which others can't, or tactile hallucination in which patient can feel. Like if a patient feels insects are crawling on her body, but you can't see any insect, that's what is called tactile hallucination, which is common in cocaine abusers. So delusion, hallucination, and disorganized speech means if you don't understand whatever the patient is saying, that's disorganized speech. Disorganized or grossly catatonic behavior. So their behavior is very disorganized, like whatever they are talking, their posture, everything is very disorganized and you don't understand what they are trying to say. The negative symptoms are called the symptoms that a normal person should have, but your patient don't have it. That's mainly like flat affect. That means if they if they don't have any affect or mood, that means totally blunt. Sometimes they will say they are totally withdrawn from the society. The social withdrawn, flat affect, that's what is also a part of schizophrenia symptom. Okay, now at least 3 of these symptoms should be there for a period of 6 months to diagnose someone as schizophrenia. Okay, so if you have a patient who has 2 or more of these symptoms, especially one of them has to be hallucination, delusion, or disorganized speech, and that continues for at least 6 months, that's the time you can call them as schizophrenia. This lecture will continue for at least another half an hour. Okay, so sign and symptom of schizophrenia are positive symptoms and negative symptoms, as we discussed. So positives are delusion, hallucination, thought disorder, or disorganized speech. And these are the negative symptoms where patient have flat affect. That means no emotion at all. Okay. Then poverty of thought. That means they can't think at all. If you ask them that, what are you going to do tomorrow? They will not say anything. That means they can't think that what they are going to do. Lack of motivation, social withdrawal, and reduced speech output. So these are the negative symptoms. Negative means a normal person should have it, but schizophrenia patient does not have it. That's why it's called negative. Okay. That means a normal person should have a normal affect. Normal person should know how to think properly. They have motivation. They are social. But schizophrenia patient is just the opposite. Always try to rule out the possibility that if the patient is under a drug, before you can diagnose someone with schizophrenia, you just need to rule out the possibility of drug-induced psychosis. So what is the management for a patient who is diagnosed with schizo? Now, the best management is the atypical antipsychotics. We no longer give typical psychotics as part of the first-line medication. And you need to give treatment for schizophrenia. There is no cognitive behavioral therapy or psychotherapy for it. So the typical initial therapy is olanzapine or risperidone. Even like you will say that risperidone is more commonly used rather than olanzapine. So if both option is given in the exam, then choose risperidone. If response is inadequate in 3 weeks, then you will increase the dose according to the guideline. If no response after 4 to 6 weeks, then you can consider changing it to another antipsychotics and choose from an alternative second generation or atypical antipsychotic. And what are the common atypical antipsychotic we have got? We will just come into that in a moment time. Sometimes if atypical or second generation antipsychotic does not work, then you have the option of giving them first generation or typical antipsychotic. Why we don't like typical antipsychotic? Because they have more side effect. So those are your haloperidol, chlorpromazine, all of the others which people used to use before. Nowadays, we don't use it. Sometimes haloperidol can be used because it can be given as a IM or IV, but others very unlikely. So that brings me to the second thing, like if a patient who is having active psychosis can become very violent and aggressive. They might want to just remove their IV line. Okay, they might want to harm themselves. So a aggressive, agitated psychotic patient, you can't give them oral medication initially. So that's the time you can either give them haloperidol IM or olanzapine IM. Okay, so these are the best two options that you have got. So management of schizophrenia is always starting with atypical antipsychotic, which means that you will use risperidone or olanzapine. If that does not do anything in 4 to 6 weeks time, change to some other second generation antipsychotic. If second generation antipsychotic not doing anything, then you can go for first generation antipsychotic. Sometimes you might need parenteral antipsychotic, especially for a psychiatric patient who is very agitated. Then you have to give either a IM dose of haloperidol or olanzapine. You might have noticed that I have not touched the dose anytime so far, right? Which means you don't need to know the dose for the exam. You just need to know the name of the medication. Okay. Now, for a long-term chronic schizophrenia, what are the choices? Same. So you will choose from something atypical like olanzapine or risperidone or quetiapine. We always aim for the lowest possible dose to maintain a control. Now, there is a condition called drug-resistant schizophrenia. So what does it mean? If you have tried 3 antipsychotic, and that's also the maximum dose of 3 antipsychotic, still patient is having features of schizophrenia, that's what we call as drug-resistant schizophrenia. And that's the only time you will try clozapine. Clozapine is the, you can say, the most effective antipsychotic in the market, but it is also having the worst side effect. Excuse me, guys. Just one second. So I was saying that clozapine is the best medication, but it has like a lot of side effect. So that's why we keep it for the end, the last option. Why it is something which is very serious? Because it can cause blood dyscrasia. That means you can develop agranulocytosis. You can also have cardiotoxicity, like the patient with clozapine can end up having a heart issue like a pericarditis, myocarditis. So question comes that a patient is on clozapine, complain chest pain. What will you do next? The next is always doing a ECG and then do a troponin. Okay, and then you can do a echocardiogram. But if you have a patient complaining chest pain on the top of clozapine, stop the clozapine. Okay, because the likely chance that it has caused a myocarditis. Same that a patient on clozapine and you found out that patient's WBC count, especially neutrophil count, is going down, okay, and patient having some features of infection, there's likely that clozapine causing neutropenia. Same, you will have to stop it. Now, is there any other choice? If you have given clozapine, is still patient not getting better, the last option is ECT, electroconvulsive therapy. Now, the antipsychotic drugs can also cause a lot of side effects. So what are the common side effects? One of them is called acute dystonia, in which patient develops kind of a bizarre muscle spasm of their face, neck, and tongue. So kind of like just a muscle spasm. And the treatment is commonly we give benztropine for that. There is another side effect called akathisia, in which patient develop subjective restlessness. So they can't sit and they just having a restless foot. If they say something like that, think about possibility of akathisia. Normally, you just need to reduce the dose of it. If reduction of dose does not do anything, you can use benztropine or any of the others. So these are very common. Acute dystonia, akathisia comes in exam also, so remember it. There is also another side effect called Parkinsonian-like symptom. So what happens that sometimes antipsychotic drug can give you features of Parkinsonism, in which patient develops like an abnormal Parkinson-like gait. They will become very slow to move, postural instability, and tremor, just like a Parkinson patient. For someone who is on antipsychotic having Parkinson-like feature, the best way is to lower the dose if you can. If can't, then you can use them like benztropine will be the first choice. You can use benzohexol or phenothiazine in these patients. Not very important, does not usually come in exam. Just remember it. There is another condition called tardive dyskinesia. That's also a side effect of antipsychotic drug. In this case, patient develops abnormal involuntary movement of their face, mouth, tongue, and limbs. And usually it happens after a long-term use of antipsychotic drug, like months or years. Whereas this acute dystonia usually happens early in the treatment. But tardive dyskinesia is much worse, in which patient can't even stop moving their limbs, and they will have abnormal movement of their face. So that's tardive dyskinesia. You just need to make sure that either you can stop the drug or you can use tetrabenazine for this patient. Not commonly asked in the exam. Remember, initially we discussed about this neuroleptic malignant syndrome. This is a potentially fatal adverse effect. That's why it is important. It can develop in hours to days of starting the medication. So patient with this condition, after starting antipsychotic, they will develop high fever, even sometimes above 40, muscle rigidity, and altered consciousness. Immediately stop the medication. Ensure patient having adequate hydration with IV fluid. If patient becoming very serious, then you can give them bromocriptine or dantrolene. I haven't discussed with you the serotonin syndrome management. What's the management of serotonin syndrome? Immediately stop any serotonergic medication patient is taking. In here, you don't need to gradually reduce the dose, just stop it. And then just symptomatic management. If a patient getting a significant serotonin syndrome and patient is still not better even after stopping the medication, then your option is cyproheptadine. That's the antidote for serotonin. Okay, so that's your serotonin syndrome management. For neuroleptic malignant syndrome, you know what to do. Now, coming to the most important one, which usually comes in exam from antipsychotic medication, is their side effect. You will need to know about it because a lot of questions come from here. No, Dr. Rubia. So all those side effects that you have seen, that's the side effect of any antipsychotic. And it's mainly common with the typical antipsychotic like haloperidol, chlorpromazine. Atypical antipsychotic, usually not that much, but still they can give these side effects. Now, these are the second generation antipsychotics. So you can see amisulpride, not very commonly used. Aripiprazole is important. Clozapine important. Olanzapine, quetiapine, risperidone. These are the commonest antipsychotics that is used in the market. Now, the side effects are very important to know because questions come from here. First of all, we will look at the same one, olanzapine, quetiapine, and clozapine. These three medication gives metabolic syndrome, which means it causes increased weight, it causes hyperlipidemia, it causes hyperglycemia. So you can look here that clozapine, dyslipidemia, 3+, hyperglycemia, it can give orthostatic or postural hypotension, and it's very sedative and weight gain. Same with the olanzapine. You can see it can cause dyslipidemia, 3+, hyperglycemia, and it's also sedative and cause weight gain. Same with quetiapine. It gives a little bit less dyslipidemia. It can cause hyperglycemia. It can cause sedation and weight gain. But it's a little bit less than this clozapine and olanzapine. So basically, these three gives metabolic syndrome. Then you have risperidone, very commonly used medication. Risperidone main side effect is hyperprolactinemia, in which patient gets like a whitish discharge from their breast, which is galactorrhea, or they can also get gynecomastia. So that's what is the main side effect. The other side effect, which is also common, is postural hypotension with risperidone. All right. Now, aripiprazole is one of the medication which has least side effect. So it does not give you dyslipidemia or any other metabolic syndrome. It does not give you hyperprolactinemia. But it's not highly effective medication. That's why we don't use it as a first line. The question comes, let's say you have started a patient with risperidone and patient started to get galactorrhea. What will you do? You can't continue the medication. The best option is that you change the risperidone to aripiprazole. If aripiprazole is not in the option, then change it to quetiapine. Okay. If a patient on olanzapine getting diabetes, getting weight gain, what will you do? You will obviously ask the patient for some lifestyle modification, lose some weight, do some exercise, but better option is also to change it to aripiprazole. So these two questions come in the exam. Remember it. Apart from schizophrenia, there are also some other psychotic conditions that we should know about. We call it brief psychotic disorder. So you remember that to diagnose schizophrenia, the time duration of psychotic symptoms is at least 6 months. But when a patient has got symptoms just for less than a month, that's what we call as brief psychotic disorder. So you have got all the symptoms of psychosis, but the symptoms are more than 1 day, but less than 30 days. That's what we will call as brief psychotic disorder. Okay? Go through this question and you will understand the symptoms also. The treatment is same. You will need to start them with antipsychotics. There is another condition called schizophreniform disorder. Now, schizophreniform disorder also have all the psychiatric condition or psychotic condition, but the duration is the only difference. In here, patient will have these psychotic symptoms more than a month, but less than 6 months, which means less than 1 month symptom means brief psychotic disorder. 1 month to 6 months, that's schizophreniform illness. And more than 6 months, that's schizophrenia. Okay? The treatment is same. Last 2 topics for our tonight session. One is schizoaffective disorder, another is delusional disorder. So what is schizoaffective disorder? The name says everything. So you can see that patient will have schizophrenia symptom like psychotic symptoms and also have affective disorder. Affective disorder means either depression or mania or hypomania. So when a patient has got psychotic features as well as depression or manic feature at the same time, and then there was a time that patient had just hallucination or delusion for at least 2 weeks in the absence of any other mood symptom, that's the time we call them as schizoaffective disorder. I know it is confusing. Let's just read this symptom first. A 25-year-old woman is found walking nude in the shopping mall. When asked why, she replies, I am making it easy for others to have sex with me since I know they all want me. She stated she heard a voice telling her she was irresistible and everyone wanted her. So she is having hallucination. When she speaks, she cannot focus on one topic at a time. What does it mean, guys? This is called flight of ideas. Her mood is euphoric, affect labile. She recounts an episode last year where although she did not have elevated or depressed mood, she heard voices she could not describe. So there was a time last year where she only had schizophrenia symptom, nothing else. At the moment, she is hearing voices and she's having mania symptoms. So patient having schizophrenia symptoms and affective symptoms. So together we call it schizoaffective disorder. Is this clear for you guys? So when a patient has got features of schizophrenia, features of depression or mania at the same time, and then there was a time where only patient had hallucination or delusion without any mood symptom, that's what we call as schizoaffective disorder. In these patients, you will need to start them with antidepressant medication first, and also sometimes mood stabilizers. But if antidepressant does not help, then you will also need to add a antipsychotic drug. All right. Did you guys get the schizoaffective disorder part? Any confusion? All right. Moving on to the last topic for tonight, which is delusional disorder. So delusional disorder means that patient will only have abnormal belief, nothing else, no other schizophrenia symptom. So have a look. Mr. Smith has been married for 10 years. During most of those years, he believed his wife was trying to poison him to get his money. So that's his belief, right? He frequently complains of a stomach pain, which he believes is due to the poison in the food. His thoughts are logical and coherent. Now, in a schizophrenia patient, thoughts are disorganized, not logical. He denies any hallucination. His wife, an independently wealthy woman, does not understand her husband's logic because she has more money than he does. So only problem with delusional disorder that they will have an abnormal belief and they will function normally. They will not have any problem with their social or occupational life. Their thoughts are fine. They don't have any other hallucination or any other features. Okay. So it's called non-bizarre delusion for at least a month, no impairment in the level of functioning, and patients are usually reliable. Okay. So many times you will see that this type of question comes. A university professor thinks that aliens are going to attack this planet, and he keeps on thinking about it, even though there is nothing he has got as a proof. But he's a university professor, and he is teaching the students without any other issues. He does not have any other problem. So that means this is also delusional disorder in which patient only have delusion, nothing else, and they can function normally. Whereas schizo patient will not be able to function properly. Okay, so for this kind of things, what is the treatment? You can give them some antipsychotic medication if it is really needed. Many times patient will not need anything. It's just like how they are. It cannot be treated. Okay, let's just do this case and then we will finish our tonight's session. Let's read it. So 74-year-old man hospitalized due to severe depression and a 4-kilo weight loss over the last month. Family members report that he has become progressively withdrawn from friends and family, stopped attending his weekly bridge game, refused to leave the house. He sleeps poorly and ruminates at night about his financial situation. Patient has a history of depression and responded to TCA 30 years ago. And also he was given a SSRI, which was ineffective. In the hospital, efforts to get him to eat are unsuccessful and he barely drinks. Now, this is something which is very important. If a patient stops eating and drinking with a severe depression, there is something that we can do. On mental status exam, patient's eyes are downcast. He gives brief, barely audible response. He reluctantly discloses that he has been hearing the voice of his brother who died 15 years ago. So this is a severe depression with psychosis. And you have tried antidepressant twice, nothing has happened. Patient stopped eating and drinking. What is the most appropriate treatment? Antipsychotic, CBT, ECT, monoamine oxidase inhibitor, SNRI or TCA again. This is the time we choose ECT. Okay, so ECT has some guideline that you guys need to know that is the last option. You have tried psychotherapy like CBT, you have tried medications, still patient did not improve, rather getting worse. And especially if they stop eating and drinking, that can be life-threatening. With that, patient has got psychosis also. This is the absolute indication for getting into ECT. But for ECT, do you need to have the patient consent? Yes. If a patient can give the consent, then patient consent can be given. But many times this kind of patient will be very mentally unwell that they lack capacity to give consent for any medical treatment. That's the time you will need to get a consent from tribunal. So tribunal is a court who will be able to give consent for this ECT. Okay, so usually before going for ECT, you need the tribunal authority to give you the permission to go for it. The only time you can avoid that is that if it is a life-threatening condition, that patient is severely dehydrated and patient is dying. In that case, you don't need to wait for the tribunal authority to give you the permission. As a duty of care, you can start the ECT. As long as 2 psychiatrists are happy to go for ECT. Okay, so that's mainly what they usually ask as part of ECT. This usually they give you a scenario and then they ask questions from here. Okay, so what is the diagnosis in here? Severe depression with psychosis. So that was all about tonight class, guys. As you can see that the AMC MCQ is not very easy if you don't know this, right? Now you know it, it becomes easy for you to understand. If you give a read again, things will become very, very clear for you. But if someone does not go through this with you, you will never even know that what to read and what are the important things. So that's why we always say that come and go through the classes and obviously it will help. Now I would go through with you about the course a little bit. We will not prolong the class anymore because I know that for the first class, you have already exceeded that time, right? So let's just go through our course facts and everything. I will just open the details and then we can go through that. Okay, just give me 1 minute. So if you go through our first aid AMC MCQ group, you can see this features section will allow you to go through the important things. You can also get recordings of our previous trial class here. And this is actually our updated course details in here. And you can also go through our software to have a look about the course detail. So the course mainly entitles is that, as you know, that this is our first session of the trial class. The 2 weeks free session is going to start from 13 December. Same like today, so it will be live on Zoom. The Zoom ID is the same which you have joined today. You can go through our full course details from this link, which is given in this group. Now, the main thing that, as a summary, this course has everything that you need to pass the exam. You don't need anything extra. So we mainly go through the whole theory, everything that you need for the exam. So we mainly follow JM 8th edition and also time to time Kaplan Step 2 CK. And there are some Australian guidelines for each of the topics. We will go through that when we need it. We will, usually one class every week will be taken on recent question solvation. So Dr. Rabia, who is a brilliant doctor who also passed her exam, she is also starting to work in Australia. So she is going to take one class every week on the recent sample questions. And you have got 5 years of sample question discussion back in 2018 up to 2023. So all of these questions, discussions with the video recordings are already will be given to your software or your portal. You will be able to go through those and just finish everything that's needed. And also the updated questions will be discussed every week by Dr. Rabia. Okay. So the monthly question solvation will be done by her, and you will get also class in these 2 weeks free sessions with her, and you can see how is her class. There are lots of mock tests available. So the way we take the classes, that there are 3 classes in a week time. 2 classes will be theory based. 1 class will be taken by Dr. Rabia for the recent question solvation. There are 2 types of question solvation we do. One is after theory, I do some question solvation classes based on the theory with you. And the other one is Dr. Rabia, who does the random question solvation. Then in your software, exactly same like your AMC MCQ exam, you will be able to do mock test. So it's a time-based mock test. You will get some subjective mock test like cardiology mock test, ECG mock test, psychiatry mock test. Then there are month-wise mock tests, like let's say Dr. Rabia discussed July questions, then you will get some July mock test. And then there are some full grand mock test, which is 150 question mock test. That's usually we advise to go for it just before your exam. You will get a Q bank free of charge, which will be given as part of your access to the software, and also you will get a PDF of it. You will get access to the course note. Recording of every class will be given in your portal, and it will have a prolonged access even after finishing the course. We will also discuss about job application, APRA registration, CV writing. I think many of you have joined one of the class on 26th of November, where we discussed about it, right? So that's a little bit of summary. Apart from that, you will also get extra classes on a lot of other things, like we do extra classes on ECG, your fundoscopy, CTG, imaging, like X-ray, CT scan, everything that you need for your exam, it's already there. Okay, I would advise you to go through our this full course details from here as well, from our portal, and you can get idea, the full idea about the course from there as well. Okay, this is our website address. You can go through this. Now, you have already got the schedule for the first 2-week session. Please just join the live sessions as it is given in here. And the Zoom ID is given here as well. Okay, so that gives you an idea about the course, but you can always ask questions anytime during our these 2 weeks free sessions. Okay, so I can see that you guys are writing questions. You can also just unmute yourself and ask questions here. That's not a problem.
Hello, doctor. This is Fayaz. I have a question.
Here.
I think I did send you a message on Messenger, but it looks like didn't get through. I have an issue. It's not an issue, but it's basically it's a question in regards to the timing. I mean, I've been graduated like 32 years ago. So since 30 years ago, 92, graduate of 92. So for last 20 plus years, 22 years, 22 to 25 years, I haven't practiced medicine. I've been working as sonologist and doing scans since the last 20 plus years. So I've been getting tired of that. So I don't know if
it's fine, dear.
Yeah.
Yeah, it's not impossible, but what will happen, Dr. Fayaz, is that once you start preparation for your MCQ, there is no age limit for this exam. A lot of people, even with your gap, they do that. It's not an issue, as long as you will need to have a recency when you are applying for a job, which means you will need to work somewhere, because a long gap like this, you will need to have some experience again in a hospital or a GP setting. So that's what you should do after passing the MCQ.
Yeah. Okay. All right. That shouldn't be an issue, I believe. Yes. Because I'm still working in the public setting as a sonographer, sonologist. So
yes.
So
this should be fine.
Yeah. So that was my concern. Yeah.
No worries, dear. Thank you.
Good. Thank you.
Hello, doctor. I'm Salma from Sydney. I have some query about the classes. Actually, I'm wondering about the weekdays of the class, like which day you are going to take the class.
Okay, so as part of the normal course, the timing is we normally take 3 classes.
Is it weekend or weekdays?
So one will be in a weekend, which is one of my classes will be on Sunday. Then there is one on Tuesday, and then there is another is on Wednesday. So Sunday, Tuesday, Wednesday is our usual class.
So it's actually Tuesday, Wednesday, and all of the classes will be online class, right? It's no offline class.
Yes.
Like
no offline class, but
it's
offline means
online
that
based.
Yes, it's an online based. Now let's say that you can't join a class because you might be busy or you might be doing something. Then you can just go through our class recordings as part of an offline one. So that's the only offline thing that we have, but not any on-site.
Okay. And what about the time? Like, is it
Time at the
evening
moment,
or
because
day?
yes, it's always evening. So usually the same time like today.
From 8:30 Sydney time.
Yes. Usually, and sometimes because now it's in Sydney, it's the daylight saving going on. That's why we are doing it as 8:30. But because anywhere in Australia at the moment, now it's 9:49. In your Sydney, it's 10:49. So what we do at the moment is that, so just we take it 8:30, but when this daylight saving time is over, then classes come to 7:30.
Yeah, I got it. Actually, I'm working. That's why I have so much confusion about the timing of the class.
Yeah.
So
A
yeah,
lot of working
but thank
people
you
do
so
the
much.
classes, not, yeah. Okay, so
Mhm.
that's not a problem at all, Dr. Sama, that there is a huge number of candidates who join the course, but they can't join the live sessions. They just go through our recordings. And that's, if you can just finish every classes just after the class is done, then you will not feel like you are not even doing the live sessions. Because these are video recordings, if you can finish it with us, then it becomes just normal.
Yeah, actually, I prefer live session. That's why.
Yeah. No, live session
Okay,
is
no, is
always
the
best. There is nothing better than that.
timing sounds yeah, the timing sounds good for me right now. So yeah, I think it will work out.
No worries, dear. Because all of us work in
Thank
Australia
you.
who are taking the classes, so it will never be in the morning time or afternoon, because we also come after work at the evening time. So we can only take classes this time.
Yeah,
So this should be fine.
yeah, that's true. Yeah. Thank you so much. And today's class was really helpful. Yeah.
That's all good. Thank you, dear. Okay. So
Hello.
the other questions is Dr. Mehdi.
Doctor, I am Mary from Bangladesh. I have a question that
Yes.
all three of your classes is taking working day. In Bangladesh, we have working day on only Friday and Saturday. So is it possible that on these 2 days you should take any of this class?
Unfortunately, it's very unlikely because Saturday we take the clinical classes. So Sunday is usually we do that MCQ class. Very unlikely that that will be changed.
Okay, I have another question that you said lots of resource like 2 or 3 books, many websites and AMC lecture notes. If I follow only MC, your first aid lecture notes, does it cover everything or we should take in any other
It
books
covers
also?
almost
Should read?
everything. It covers almost everything, Dr. Mehdi, but always we say that, like, you might need to read a little bit from JM, which we will ask you to do in the class, like read this one from JM, read this one from Kaplan Institute. So you will get that idea that which one to read. But if you can finish what we are saying, that yes, that should be fine. Then also sometimes we will ask you to read the Q-band because that we don't cover. You will need to read it by yourself. So most of the theory and questions will be covered, but some of the things you will also need to read from a couple of areas. That's how usually everyone does.
Okay, thank you. My last question is that on today's lecture, on today's lecture, in which from which book you studied today?
Yeah.
Actually, my
So
English
it's
is
a
not.
combination of, it's fine, I can understand it. So yeah, your today's class is a combination from JM and also Kaplan S2CK mainly. So usually in our lecture note, always there will be a combination between these two, JM and Kaplan S2.
Okay, thank you very much.
Okay, so I can see Dr. Jenny asks, so if we are the only doctor in the ward, patient with severe depression and psychosis refuse to eat and drink, can we give ECT? No. If you are a junior doctor in the ward, you can't decide it. And in the ward, there will be someone senior than you. So the question will always ask you to consult a psychiatrist. ECT cannot be given without a psychiatrist, okay? And you will, most of the time, you will need a tribunal consent before you do that. But only time the duty of care comes into play, that if the patient is dying or very life-threatening, that you can't even wait for tribunal. And Dr. Rubia, so yes, if you do all the notes and whatever we are saying you to read, then yes, it should be enough. You don't need to read from a lot of books. We never ask you to read from a lot of books. Only books that we ask you to read is JAM and Step 2, but that's mainly covered in our theory session, almost everything. Time to time, you will need to read the Australian guidelines. Like we have for medicine, we have RSCGP guideline, for pediatric RCH guideline. Those guidelines, everyone read it, and that's a part of your preparation for MCQ. So you will read it anyway, because when you do the question solvation, you need to read those topics. When the course is going to start, actually course is going to start on 6th of December, but your 2 weeks sessions are going to start from 13th December. 6th December, there is no class. The 1 week gap is mainly for us to add you to the portal and add all the things to your portal. But your classes will start from 13th of December as we have given in your schedule. And yes, the classes in a week is 3 classes in a week. The next class is on 13th of December. The timings are same for all this, that's right. No, the Christmas time, we will give you some break. We normally don't take classes during Christmas time. If you look at the schedule, we haven't kept any class during that time. All right, but around 27th, 28th, we will have 2 classes, but not during Christmas time, like not even on 23rd, 24th, or 25th. And the classes are on Sunday, Tuesday, and Wednesday, Dr. Shankari. The lecture notes are in the portal. So once you join the course, then you will get access to our portal. Then you can get all these notes and recordings. And the full class schedule, Dr. Madiha, we haven't given it yet. Once you join the class, then you will get the schedule. And the topics are always written, Dr. Devi. If you even look at our class schedule, you can see that it's already given what topics we are going to do, right? Like, let's see here. See that 1st December psychiatry trial, 13th December tips and tricks. So all the topics are usually given before we take the class. So you will know that on which subject we are taking the class before we do that. Okay, that's how we normally do it anyway. Okay, so that should be all. Is there any other questions that you guys are having? Anyone in the Facebook? Do you guys have any question? No, normally like we
excuse me.
we don't need to give you that much topic. Yes.
Excuse me. Sorry. Hello. May I know
Yes,
the duration of the
Senura.
course? What is the
Yes.
what is the exam you all are aiming for this this commencing program? February or March or
So
for
it's
how
a
long
5
the
months.
course? 5 months course, no?
So it's a 5 months
Okay.
course. Yes.
Okay.
Now,
Okay.
for
Thank
a
you.
lot of people who has exam before 5 months course is done, like someone might have an exam in March. So what we do normally, that if someone has got an exam, already placement has been got, that means you have got a placement in your in the AMC for an exam earlier than before our course is finished, we give you the access to our previous course. That means the course that has been finished just now. And you can go through that course materials, recordings of all the classes, and you can finish the course in your own time by getting the past class recordings. The only thing that we need you to give that access is that you have to show us your placement. And then you can finish your course with your own time, and even within 1 to 2 months if you are very fast enough. You can join the live sessions in the new batch as well, as long as you are going for the exam. Okay, so that's also one of the other things. All right, guys. So again, I will meet you on 13th of December. We will come with some tips and tricks to solve questions, a little bit different from tonight's session. And then you will get some classes with Dr. Rabia. And the course admission is already going on at the moment. So I would advise that if you actually like the classes, just get enrolled, start the process, because it takes some time for you to enroll. There are lots of processing. So just make sure you start the process, either send us an email or send me an inbox, and then we can just start the process anyway. Okay. Thank you, everyone. Have a good night. Take care.